valve, tricuspid valve, pulmonary valve, and they can cause both stenosis and narrowing of the valves as well as the regurgitation. So these are the valvular heart diseases. So one aspect, you have myocardial diseases, you have valvular heart diseases, you have electrical diseases. Difficulty, complexity in pathologies is the electrical conduction system of the heart, which can be both bradycardia, that is heart blocks. You have heard about the SA node, the AV node, fibers, bundle of this. If there is an obstruction at any level, called blocks, heart blocks, SA blocks, AV blocks, conduction system blocks, lower down, left bundle branch block, right bundle branch block. And the electrical diseases can also manifest into fast heartbeat, that is tachycardia. Paroxysmal supraventricular tachycardia, ventricular tachycardia, sinus tachycardia, atrial tachycardia, so on and so forth. So these are all the terms you will hear as you progress in your. These are fourth semester or first year. First year. So there is some introduction to anatomy and physiology, but no introduction to clinical science. So as you will move into medicine and pediatrics and other specialties, a little bit, may have some of you may have elective postings in cardiology also. So you will keep on hearing these terms. But today what I want you to introduce, and I'm not sure whether I'm going too under or too over, but for the best of my capabilities, today I want you to remember that diseases of heart can be broadly classified into myocardial diseases, valvular heart diseases, electrical conduction system diseases, both bradycardia and tachycardia, pericardial diseases, constrictive pericarditis, pericardial effusion, pericardial diseases, and coronary artery diseases, about which we will be dealing. Okay? So I will not be dealing with myocardial, electrical, pericardial, valvular diseases. I will only be dealing with coronary artery diseases. Okay? And the reason is pretty simple, that the so coronary artery diseases are important because each one of you, if you have not heard till now, very soon, in the next 3 to 4, 5 years, you have one of your close friends, parents of close friends, your first degree relatives, suffer some sort of coronary artery disease because of its simple presence. And I'll give you give you a sense of scale of the problem of coronary artery. As we are speaking today, 25% of all global mortality occurs because of cardiovascular disease, of which coronary artery disease and stroke are more common. 25% of all global mortality as we speak today, 1/4 of human population is dying today because of cardiovascular diseases, predominantly coronary artery diseases and myocardial infarction. And to give you a sense of scale, that is 25%. The next biggest killers are respiratory diseases and malignancies. And they account for around 14 to 16% of all mortality globally. Then it comes somewhere around trauma and other issues and infective diseases that we really read so much about. I'm not undermining, because infective diseases really cause mortality in early stages of life. It's most productive in the perinatal period, in the natal period. Nothing to undermine that, but to give you a sense of scale, all the infective diseases combined, the global mortality is less than 2%. So the 2% and 25% of mortality is a huge difference. The non-communicable diseases should be a very, very important. And all of you will hear about some or the other known person being suffered from coronary artery disease, and they will come and ask you for about to become doctors who are in medical college, and I have had this anterior wall myocardial infarction. What should we do? I have this unstable enzyme. I am diagnosed with non-SC segment elevation MI. You are confused what to advise them. So I just want to make you comfortable with all the things that surround, all the nomenclature that surround coronary artery disease, and how they interface, what are the various spectrum of the diseases, how can you relate a little bit about the anatomy, the knowledge of anatomy and physiology you are gathering now, and try to assimilate and correlate with the manifestations of coronary artery disease as you move forward. Am I with you all? Is there, आप लोग सबको समझ में आ रही है बात में क्या कहना है? Any person who is finding it a little difficult? in the English combination, any discomfort level? Should I be writing or no? So, so myocardium, as you see here, is the muscle that continues to beat, and it will require its own coronary artery. It will require its coronary arteries to supply blood to it. If there is less blood being supplied to myocardium, they will not function adequately. And this is the whole muscle, and these are the two grooves that are present. You may have heard in the anatomy. This is the interventricular groove in the right ventricle, in the left ventricle. And these two on the right side and on the left side are AV grooves. That is between the left atria or right atria and right ventricle, and left atria and left ventricle. So the entire structure of coronary artery is built on the concept of these grooves, because the entire structure of the heart would require blood supply of its own. So the distribution has to be managed mathematically. If it's not managed, one or the other area of heart will receive less blood, and you will have problems with the less blood supply. The problems may be acute, suddenly happening, like attacks that we call it, short-term myocardial infarction, or it may be chronic, gradual. You don't have a sudden heart attack, but you have angina on it. Whenever you move fast, your blood needs more, your heart needs more blood supply. One particular area of the heart is not being supplied adequately, and it cries out of pain, asking for more blood. That is that. So coronary arteries, broadly speaking, can be classified into asymptomatic disease, where you have a narrowing in the coronary artery, but you don't have any thickening. They can further be divided into sudden, you have a plaque or an atherosclerotic lesion in the coronary artery, let's say 20%, 30%, 40% narrowing. At this level of narrowing of 20, 30, 40, 50%, there is no critical narrowing. So there is disease present, but the patient is not having it, because even if the patient excites because of the simple principle physics, if the lumen is more than 50% still, the blood supply is still continues to happen, and you all realize that it's absolutely happening. But suddenly these 20-30% lesions can rupture. You read in pathology, not in physiology, but you read pathology, the concept of a vulnerable plaque. There is lesion, which we call as plaques. There are some plaques which are vulnerable to rupture, and there are some plaques which are fibrotic, which are less likely to rupture. So vulnerable plaques are defined as plaques that have got a lot of inflammation, a lot of neutrophils, a lot of lipid in them, and the cap of the plaque is very thin. Thin cap plaque, lipid-laden plaque, and more inflamed plaque is more likely to rupture. Now, what happens when the plaque ruptures? You've been reading physiology or surgery. What is Workhouse trial? So you will read about it. So three factors promote clotting. So clots को form होने के लिए तीन factors जरूरी होते हैं. कोई hypercoagulable state हो सकती है. It can be slow, sluggish flow. अगर flow sluggish है. Third can be exposure of blood to foreign particles. Foreign particles से किसी भी foreign activity से blood normally exposed नहीं है, तो उससे expose हो जाएगा. So clot will form because it will tell that the foreign body, that's the reaction. If the blood flows out, that's another thing. It clots. So clotting is promoted by the combination of these three factors: hypercoagulable state, exposure to agents that blood is not familiar with, and stasis, so forth. So these are three factors. So what happens when plaque ruptures? The plaque throws up inside the blood vessel some cholesterol, some particles, some calcium. Now, flowing blood is not accustomed to seeing free fat inside it. So clot formation occurs, platelet comes, fibrinoid comes, and then artery suddenly appears. So that is the concept of myocardial infarction. That is the sudden occlusion of blood vessels because of the rupture. Remember today that these plaque ruptures happen on vulnerable plaques, Vulnerable plaques are generally plaques that are 20-30% in diameter with a milder degree of stenosis. In narrow तो कम करते हैं, लेकिन rupture के लिए ज़्यादा vulnerable. So अगर कोई कहे कि आप हमें लिख के बता दीजिए कल को मेरे को MI होगा कि नहीं होगा, will I suffer from it? There's absolutely no way of finding out because अगर आप 20-30% lesion check करेंगे भी तो हर body के अंदर हर person की body के अंदर ये 20-30% lesion है. देखने से पड़ेंगे कि fatty streak जो है ये plaque formation starts in the first year of your life. Some people progresses faster, but most of you will be having small plaques here. So anything can rupture at any given time. There is absolutely no way to detect it by either PMC, credible tests, or CT There's no way you can predict a plaque rupture. And whenever a plaque rupture happens a sudden clot inside the coronary artery, can be anything. If it happens in the LAD, I mean, either one myocardial infarction, but I'll come to this. So the concept of plaque rupture producing MI needs remembered, and these plaques that are more prone to rupture are in a milder degree of stenosis. So 20, 30, 40%. More than 50 to 70% of all myocardial infarctions are caused by lesions that are health. They are present, they are not symptomatic, suddenly happen. And the third presentation, one is the manifestation of coronary artery disease can be asymptomatic, can be acute coronary syndromes, there's clot formation inside, and the third can be stable at time. Now suppose you have a clot that was 30 to 50%, that it did not rupture, but over a period of time, because of diabetes, hypertension, and all of the smoking, tobacco, all the risk factors. So what these risk factors do? Why do we say that you have to control these risk factors? Because they promote plaque formation and they accelerate the process of growing of that plaque. So if you have uncontrolled risk factors, these vulnerable plaques can ultimately become non-vulnerable, but they start speeding up in their growth. They have more fibrosis, more calcium, the plaque grows, and now it starts to cause a lesion that is more than 70 to 80% diameter stenosis. And now occurs a critical point because the fixed stenosis inside the artery is more than 78 to 80%. You are asymptomatic at rest. Whenever you start to exert, whenever your heart myocardium needs more blood supply, this 80% lesion prevents it from getting that more blood supply, and you cry out. Heart myocardium cries out, and what does it say? Cry out as angina. Great. Angina or dyspnea is the first example. Okay. So we have a little bit of right. Now coming to the circle and loop approach, trying to correlate in economy. So you may have been thought about so these two groups. You have four groups now. Okay? You have the anterior interventricular group, which runs on the anterior surface of the heart between right and left ventricle. You have a posterior, you have a posterior interventricular group, which will be running in the base of the heart, again between. So inside these grooves is the interventricular septum. See, if you open it up, I think I can open it up, but I don't think I can reassemble it again. But inside this groove, you have a septum. On the anterior surface of the septum is running the anterior interventricular groove, and on the inferior surface of the septum is running the posterior interventricular groove or the inferior. It's not actually posterior, the inferior surface of the heart, because we have to. Now, again, one thing that one month that I can tell, we only understand in anatomy, and after that, we completely forget it. That is that as you move away from anatomy into medical science, especially medical clinical science and cardiology, most of the things that you see or read are in two dimensions. See an X-ray, I see CAT images, most of the ultrasound images are in two dimensions. okay, in CT and MRI, you start to get clear. Many of the investigations that you see are in two dimensions. So you have to hear and read and see in two dimensions, but you have to visualize in three dimensions, and that is where concept of correlation right now. Because I can promise you that many of the experienced cardiologists also will see two dimensions, work in two dimensions, that they will not have this concept of the three dimensional concept about which I will be in a little. So you have this anterior interventricular loop where which artery is running? Left anterior descending is running. Left anterior descending takes origin from left main coronary artery. We call it left main or left coronary. And left main coronary artery divides into anything else? Circumflex. So where would circumflex be running? Please. Circumflex artery. And you right now, you just now said in anterior interventricular loop, LAD runs. Circumflex runs. Which side? Left or right? Left side. Where is it? Come in. Where is the circumflex? Absolutely correct. I'm on. Okay. So you have to understand that these arteries are running in something. Please take it. Arteries are running in something that we call in cardiology as a circular loop approach. You have a circle which is being formed by the left AV group and the right AV group. And you have a loop which is being formed by the anterior interventricular group and the inferior or posterior interventricular, whatever. Now that brings to the concept that these arteries are running in the 90 degrees angulation. Okay. Many a times that you'll see the angiogram and you'll see the various combinations. You don't see that 90, you don't appreciate that 90 degrees. You see that it's taking a curve, it's a little angulated, but they are running actually at a 90 degrees. And that's all. Now suppose in two dimensions. Okay. Maybe a little bit too much for you all. So when you see an image in a two dimension, let's say an X-ray, then I ask you an artery which is going like this. This is a concept which even DL students don't know. But I want to tell you this because they're there now. In two dimensions, suppose you are seeing an X-ray. And for class, let's imagine that you are seeing an angiogram, it's a more detailed X-ray. And you see an artery of a vessel here, any vessel. Okay? And I ask you whether it's an atrial branch or a ventricular branch. I'll give you the answer. When you see something in the straight AP view or ventricle view, you cannot say that it's in the atrium or ventricle because they are superimposed. All you can say is it's left side or right side. But if you are seeing anything here in two dimensions, there's no way you can say it's atrial or ventricle because they are superimposed on each other. Same with its atrium and ventricle, you have to come to a lateral view where anything that goes ahead would be ventricle, anything that comes towards that side, towards spine, would be atrium. Okay? Here if I ask you, a vessel is going here, whether it's right ventricle or left ventricle, that is the cap. Now you see in lateral view a vessel going here. I ask you whether it's an RV branch or LV branch. Loudly. The ventricular branch, right ventricle or left ventricle? You can never say that because here the left and the right ventricle are also superimposed on each other. In two dimensions, you just see a line here. And since both the ventricles are so in lateral views, you can never say left from right. You will only be able to say atrium from ventricle and straight AP view. Am I correct? Yeah. In lateral view, you will only be able to say it's ventricle or it's atrium. And in AP view, you will only be able to say whether it's right side or left. The combination of two views will tell you what branch it is. So let's come back to the coronary arteries and how they manifest. So here you see that's an angiogram. And this is the kind of image you see. And now you're confused. Some of your relatives give you. So what you see here is an RAO view, or you can say a right-sided lateral view, where you are seeing it's a left brain cord. This is the catheter that has traveled up from your radial artery or femoral artery. In this case, probably radial. It is femoral because you can see a catheter here also. So catheter has gone all the way from an arterial axis that is in the periphery. That's how we do angiograms. We take an axis in the radial artery or the femoral artery, and we take this catheter up, and we selectively engage the ostium of the coronary artery, the left coronary artery here, and the right coronary artery. See this catheter here, and we use this catheter if iodinated contrast inside coronary arteries and iodine. The opaque is captured by very high intensity X-rays, taking cath labs, and then this cardiac catheterization lab, the high intensity serial X-rays, and we capture this opacification of the coronary arteries by this contrast. Am I clear? I don't mind people sleeping, but if people are awake and they are, is it clear to you guys in the back? Yes. ये लेफ्ट सिस्टम का इंजेक्शन है इसमें ब्रांचेस आती हैं वो लेफ्ट सिस्टम में हमने लेफ्ट मेन खोल दिया तो एक्चुअली ये लैटरल विजन ऐसे Left main is दो branches circumflex. Left interior. तो कौन सी circumflex और कौन सी LAD? हाँ नहीं है ना बेटा देखो लाटरल व्यू देख रहे हैं तो आपको ऐसे इमेजिन करना है ये हार्ट कौन सी देख रहे हैं हार्ट ऐसे the outline of the heart. This is the border of the heart. This is the anterior surface of the heart. This is the inferior surface of the heart. This is the posterior surface of the heart. So here, this, जब हम lateral देख रहे हैं इसको, try to imagine it this way. So what we are seeing is this and this. So this is your AV groove. Okay, I don't. So this is the image that you are seeing. So this vessel that you are seeing here is the AV groove. So this is the artery which you are seeing in the AV groove. This particular artery that you are seeing, this is the disc view of the heart. This artery is running here. So this is your left-sided AV groove. As you can see here, if I remove this picture here and ask you whether it's the left AV groove or the right AV groove, you can never say because both the grooves now are superimposed on each other and you are seeing from this side. Because just because you are engaged in the left system, you know that this artery is running in the left AV. Okay? So imagine that in front of this artery is the bone structure of the heart that you are not seeing because it is not obvious. This artery is running, on the backside of this structure, but still you are seeing in two dimensions because you cannot see anything that is soft. Okay, and there is the LED running here. LED is running. Okay, now this view is the opposite view. This is right injection, but this is your straight or carryover. Okay? Now you see here, somewhere here is your interventricular receptor or AV groove, which is here. But now it's not a left injection, so you are not seeing LED. If you were seeing LED, it would have been here. But now this RCA, because when you're seeing from straight, it's making a C. This half circle, circle and loop approach. What you see here? The half C. Do you get this concept? So this was the two injections, the left system and the right system, and you have two views. Tell you, now I need a lady on the side. Okay. Okay. इस वाले व्यू में सर्कमफ्लेक्स आर्ट बताइए उस व्यू में अगर सर्कमफ्लेक्स आर्ट दिखाइए दिया कैसा दिखता है और राइट इस वाले में छूटे अगर सर्कमफ्लेक्स का इंजेक्शन होता तो कैसा बना ड्रॉ इट Any volunteers? Next to you? Look at the idea. If you are not discussing, if you are not comfortable with that, we are not moving forward. We have to clarify it right now. Who's Maria? Circumference. I told you it's a circle and a loop. मैंने बताया आपको कि इस वाले में सर्कमफ्लेक्स चल रही होगी, इस वाले में सर्कमफ्लेक्स चल रही होगी, इस वाले आपके तो करिए। तो अगर हाफ सर्कल हमने यहाँ बना लिया, very simple, you have to get another half circle on the other side. This is your half circle on the right side. It's the R. Circumflex जब हमने यहाँ पे इंजेक्शन किया था, because ये होता है कितने थे? LED यहाँ पे नहीं होती, तो circumflex बनाएगा ऐसे। Is everyone clear in this? Is everyone clear in this? Because once you know this, then you can proceed with the difference. And that's how you want to correlate. And this, I'm telling you, this correlation many a times is missing even in senior cardiologists. They keep on doing their job, but they don't have this concept. So like inferior AV group में LED रन कर रही है, ऐसे ही inferior या posterior AV group में कौन सी आर्टरी रन कर रही है? PDA, posterior descending PDA. Now PDA can come from left system of the heart or the right system of the heart. Whatever system it comes from is called as the dominant system. Very good. Now, what is the angle in RCA चल रही होगी, तो उसकी ब्रांचिंग मीडिएट कर रही होगी, ठीक है? PDA और RCA के बीच में एंगल क्या होगा? RCA कर रही है उसकी ब्रांचिंग PDA, तो PDA और RCA के ब्रांच में एंगल क्या होगा? 90 degrees, ठीक है? Now you have to remember that this artery is running like this, and if it has to come to the inferior interventricular groove, it will have to make a 90 degrees turn. Only it can help. It has to come. If it's running like this, and now it has to come there like this. In three dimension, it will have to make a 90 degrees. When you see the now, look at the problem that you face. That's a very, very important problem that anyone faces. Why this concept I wanted to tell you, not proceed further unless you are comfortable with this concept. Now you see this is the PDA. This is the angle it is coming from. When you see an angiogram, does it look 90 degrees? No, it doesn't. Is it 90 degrees? Yes, it is 90 degrees. So if you have to take something from here, let's say a stent from here and go here, you would say it's so simple. I'll just go in a straight line and the stent will move. But as soon as it comes at an angle, it gets stuck. It will not move. You have to understand. This is a 90 degree spread. This is a 90 degree spread. But truly speaking, you can presume it to be That is how PDA also looks. This is the fixed between a PDA and a PhD, but anyhow, that's not for you. PDA will also look like this, something like a little bit of an angle, data development. But you have to know in your heart, till the 90s, you have to take it, which has to come in the posterior interventricular group. Are we comfortable? Rishi? भाई साहब आप no, आपके आगे आप जो खड़े होते आपके आगे यस आपके बगल आप जा रहे हैं इस वाले को तो सर्वम पे इस वाले को सर्वम पे एक मिनट सर्वम पे लीग ऑपरेशंस पता है क्या था? लीग ऑपरेशंस क्या था? यूनाइटेड नेशंस बनने से पहले लीग ऑपरेशंस मैंने सुना है यूनाइटेड नेशन बनने से पहले लीग ऑफ नेशंस एक बार एक कार्टून आया कि यूनाइटेड नेशंस जो है लीग ऑफ नेशंस की एक ग्रेव है और यूनाइटेड नेशंस पे बीच चढ़ा है फुल चढ़ा है और कैप्टन लिखा था कि where I am you were where you are I would be तो जहाँ बैठे वहाँ पहले बैठे हुए थे और जहाँ हम खड़े वहाँ पर खड़े होंगे इसलिए because in this whole lot I can recognize by your face where your mind is and truly speaking it doesn't matter whether you are under a lot of stress, but sometimes, things happen in front of you that could change something. But from others will say your attention and it's. I don't want, whether this lecture is there or not, that's a different thing altogether. But keep your mind sharp and looking for opportunities that may be game changers sometimes. That realization. What can be and what not be is this. Okay? So, again, this is a manifestation of this is the normal coronary arteries. These are the plaques. The plaques can go on forming in thickness. And whenever it reaches a certain stage of criticality, generally it is in the range of 60 to 80, 70 to 80% of ganglicular stenosis. Then it produces obstruction in the flow of blood whenever you are exercising. Whenever you are exercising, heart muscle needs more blood supply. If more blood supply is not available because there is an obstruction, They are simple pumping valves. You have a line in your water pressure which is like 50% excluded, you still get the same kind of flow. But if it becomes 90% excluded, you have flow dripping and you have to follow some to clean up that arteries. And in the medical world, these buzzwords are the cardiologists. They clean up these arteries inside. Okay? So our job is to clean up this artery and place, diagnose it on the angiogram, clean up this segment by balloon dilatation and whether all the other gadgets that we have. And once we clean it up, there's some sort of fibrosis in the elastic recoil that starts to happen. Okay? So you see that this vessel is going out. So whenever plaques form, they kind of also dilate the vessel, do some sort of difference to the elastic structure. That's called as a remodeling of the vascular. You just clear the plaque and get out, it will grow again. So once you clear the plaque, you put it to the stent. Firstly, the stent prevents the elastic mechanical recoil, and then also the stent is coated with medications that are anti-proliferative. They are immunopathic medications, biologicals, all these are anti-proliferative drugs that are used in pregnancies, but the stent is also coated with medications so that new growth in these arteries cannot take. That's that. What happens when these plaques rupture suddenly? These plaques subsequently produce a lot of clot because the state grades the pipeline accumulate the clot formation starts from this sudden heart attack. And this sudden heart attack is very, very important concept because as I told you earlier, it's the biggest killer. So coming to acute coronary syndrome, you have this sudden plaque formation and you have something called as an acute coronary syndrome. Now these are some fancy terms that you will be reading in medicine as you move forward. If this plaque can, this sudden thrombus can completely occlude the artery. Completely occlude the artery, what will happen to the muscle? Yeah, how soon it will die? It will start dying within 20 minutes and within 24 hours nothing will be there. It will be a necrotic patch. That necrotic patch can cause arrhythmias, can rupture, kill you suddenly. Or even if it doesn't kill you, then that portion of the heart will become weak. You will develop something called as ischemic cardiomyopathy. Okay? So that's the complete occlusion. But this plaque may form and it may not completely occlude. Yeah. In this complete occlusion, you get something called the segment. Okay? So the artery is completely occluded, you get segment elevations, and you get a complete myocardial function. When the artery is incompletely occluded, you don't get segment. And you have something called as the unstable angina or non-true MI. Okay? Unstable angina means you are getting angina even at rest. The artery is occluded, now suddenly something has happened, but it's not completely occluded. So, MI semi is not occluded. ST elevation, MI is not occluded. We have heard something as the cardiac biomarkers, what are troponin, CKMP. So, whenever a small portion of muscle dies, it leaks certain enzymes in the body. Those are picked up. Those are called cardiac biomarkers. Troponin D, troponin I, ATS, CKMP, whatever you can call it. But broadly speaking, now we rely on troponin. So whenever troponin leak happens in the blood vessels and you can measure it, it means some infarction has happened, small or large. Then you call it a non-QMI. Means there was no S segment elevation, no Q wave formation, but you still had MI because enzymes have leaked. If the enzymes have not leaked, you label it as unstable. Okay? So classify acute coronary syndrome for me. Who will classify? आप classify करिए acute coronary syndrome. Acute coronary syndrome कितने टाइप के हो सकते हैं? किस बेसिस पे डिफाइन? एक्चुअली पे एलिवेशन तो क्या आएगा? ST elevation, MI, myocardial infarction or Q wave MI. इससे मिलने के बाद में Q wave मिलता है. Biomarker कितनी है तो? Unstable. The biomarker कितनी है? Which we called as the unstable. In this whole three things of myocardial infarctions, that is ST segment elevation in Q wave, non-Q wave MI, and unstable MI. All three in total account for something that we call as acute coronary syndrome. And acute coronary syndrome will happen because of a rupture of plaque and consequently sudden clot formation, sudden thrombus formation inside the coronary. Are we clear on this one? How many of you are clear? Raise your hands. How many? उसके बाद तो कोई नहीं बताएगा. How many of you are unclear? तो कोई नहीं बताएगा. Oh, please. Okay. So coronary artery में जब gradual narrowing होती है, तो वो stable coronary artery disease या stable अगर plaque suddenly rupture करेगा, तो artery के अंदर thrombus formation. This thrombus formation can have two consequences. Complete occlusion of the artery, 100% flow on the artery. Now the muscle will die very fast and a large area of muscle will die. These are called as myocardial infarction or ST segment elevation myocardial infarction because ECG and ST segment elevation, और क्यू वेव मायोकार्डियम। तो अगर 100% occlusion होगा from the start, तो इस सेमी ऐसे सेगमेंट एलिवेशन मायोकार्डियम का। अगर 100% occlusion नहीं हो तो ऐसे सेगमेंट एलिवेशन भी नहीं होगा, क्यू वेव भी नहीं बनेंगे, लेकिन पेशेंट को पेन फिर भी हो रहा है। इस presenting as acute coronary syndrome patient. Now you see whether some enzyme has leaked or not. Troponin, ATH, अगर ये लीक कर रही है तो आपके लिए समझ में आएगा कि कितना बड़ा ऐसे सेगमेंट मायोकार्डियल इंफार्क्शन नहीं हुआ है कि सेगमेंट एडमिशन हो जाए, लेकिन छोटे-मोटे मसल्स की डेथ हुई है, इंफार्क्शन तो वो भी हुआ, छोटा हुआ, तो इट विल बी कॉल्ड एज नॉन क्यू वेव ऐसे सेगमेंट एलिवेशन एमआई का अनदर सिनोनिम होता है क्यू वेव एमआई। तो इस पर्टिकुलर एंटिटी को जहां 100% उसका हुआ वहां पे उसको बोलेंगे नॉन क्यू वेव, लेकिन उसकी एंजाइम लीक करती है। अब एंजाइम भी नहीं लीक करी, लेकिन थ्रोम्बस अंदर फॉर्मेशन था और सडन डेथ में हो रहा था, तो एंजाइम नहीं लीक हुई तो वो मायोकार्डियल इंफार्क्शन तो कहलाएगा नहीं, तो उसको हम लोग बोलेंगे अनस्टेबल एंजाइम। तो एक्यूट कोरोनरी सिंड्रोम इज डिवाइडेड इनटू हेवी क्यू वेव एमआई, नॉन क्यू वेव एमआई एंड अनस्टेबल, and these are all three are acute coronary syndrome. Another entity is stable coronary artery disease that manifests with stable coronary artery disease that manifests करती है सिम्टम क्या प्रॉब्लम्स नहीं बना इस स्टेज में पेशेंट को क्या होना है, इनका तो पैथोलॉजिकल टर्म मतलब क्या होगा, एंजाइना चलेगा तो सेल होगा। एंजाइना इज नथिंग बट अ क्राई ऑफ हंग्री हार्ट फॉर 4+. ओके ओके, so ये डिफरेंसेस प्लीज ना, सो ये छोटे-मोटे डिफरेंसेस हैं उनके नॉन क्यूवेएमआई और क्यूवेएमआई। क्यूवेएमआई इज आल्सो कॉल्ड एज एस सेगमेंट एलिवेशन एमआई। एस सेगमेंट एलिवेशन एमआई में टोटल ओक्लूजन होगा, इंफार्क्शन होगा, वो फुल थिकनेस ऑफ हार्ट मसल का इंफार्क्शन होगा, एस सेगमेंट एलिवेशन होगा और क्यूवेव बनेगा। किसी की पढ़ाई बराबर? हां पढ़ाई थी। ओके, we come to the city. After that, maybe we, although there is long, but I want to end whenever you are self-receptive. We come to S segment elevations and Q wave formation. I'll tell you a secret that again, you will see that cardiologist will know. And non-Q wave MI, इसमें full thickness, पूरा obstruction नहीं है, blood का, artery का, जो नेक्रोसिस हो रही है या जो इंफार्क्शन हो रहा है वो फुल थिकनेस ऑफ मसल का नहीं हो रहा, पार्शियल थिकनेस का हो रहा है, लिटिल बिट हो रहा है, एंजाइम लीक्स हो रही है, लेकिन इसमें ऐसे सेगमेंट एलिवेशन नहीं, but still it is an infarction, it has to be treated very very fast, like acute coronary syndrome, because these both these entities are lethal, extremely lethal. Again coming to status 6. If you have infarction, what are the chances of dying? तो लोग बोलते हैं कि पीक थ्रोम्बोलिटिक एरिया में mortality होती थी anywhere between 25 to 50%. Anybody has infarction, 50% chance is going to die. जब thrombolysis शुरू हुई, clot को हम लोग ने इस clot को mechanically pharmacologically dissolve करने के लिए thrombolytic therapy और medicine देनी शुरू की, antiplatelet, medicines and thrombolytic agents, streptococcus, so mortality came down to like 12 to 13%. First fall हुआ था from 50 to 25 by the setting up of ICU. ICU बनने शुरू हुए, intensive care शुरू हुई, तो mortality 50% हो गई, जब thrombolytic therapy शुरू हुई, again 50% हो गई उसकी वहाँ से। अब प्राइमरी एंजियोप्लास्टी और स्टेंटिंग जब शुरू हुई, जिसको हम लोग मैकेनिकली अचीव करते हैं, ओवरऑल लिटरेचर में 4 to 5% mortality और बेस्ट ऑफ सेंटर्स में 2 to 3% is needed. But, but, these are figures of people who reach the hospital. Are you clear? Do you have this realization? पहले 25% मर जाते थे विक्रमोलिटी में, मतलब 5-12% मरने लगे, यूनिवर्सिटी के बाद 40% मरने लगे, हमारा बहुत अच्छा है, और इसके लिए हमारी आते हैं 2% mortality. But these are the patients who reach. A vast majority of patients die within the first hour of the symptoms happening, and we call it sudden death recognition, go on, but whatever we call it, we get day in and day out. Most recently, KGMU, what happened? To the sudden cardiac death because they didn't get the time to seek treatment. So still, overall mortality of myocardial infarction debatable, but still ranges between 25 to 40%. Most of the people who will have infarction never make it to the hospital. That makes it very, very important and very, very serious. Maybe you said that infarction, you just told me that an infarction starts within 20 minutes, and this is very, very important. This diagram is repeated many times in cardiology lectures, because we want to remember ourselves again and again, and we want to remind ourselves again and again. Significance of time in cardiology. Golden hour, high-speed center, timely PCI. So, when you give it oncolytic, the parameter of success is defined as door to real time. How fast does the patient reach to your hospital door? How soon did you deliver the hospital? When we came to angioplasty, the parameter of success changed from door to balloon time. Your time at which the patient presented to you in the hospital, the time you balloon directed this region to open of the artery. That's the door to balloon. All the time, the door to needle time was supposed to be definitely less than 60 minutes, and door to balloon time, that is angioplasty, we are making should be less than 90 minutes. That's good. I can tell you that the hospital that you work in, or the department that I work in, we have door to needle time. Door to needle time of 60 minutes is acceptable in the Western world. We have a door to needle time of under 5 minutes. Under 5 minutes. Okay? And no sooner the ECG is done, I mean, the ECG is not even complete and the needle is live and operating there. So, we have one of the highest volume cardiology centers in the country. We are one of the most respected cardiology centers in the country. That's what I want to tell you all, because I want you to have a sense of pride. Work for, you know what is happening in various departments. So this is an important graph, and it shows that this is the amount of viable myocardium. This is the amount of myocardium that you can save. If you intervene in the first 1 hour, you can save up to 80%. But if you delay it to more than 6 hours, hardly anything left to save. You get a realization of what is the importance of time. This is a very important chart. That if you open up this acute blockage, acute coronary syndrome, I'm talking about ST segment elevation myocardial infarction, and there's a total obstruction of the coronary arteries. You open up within the first 1 to 2 hours, you save 70 to 80% of time. That could have died. But if you delay it to more than 6 hours, 12 hours, there's hardly anything left. Now this graph again is of pre-combulative, pre-aspirin combulative area, but now also we say that if you are not able to do anything, open up the artery between 12 and 24 hours, that's the limit. Beyond 24 hours, you should not even try to open it if it's occluded, because the muscle is infarcted, the artery is occluded. You open up some collaterals are formed. If you open up, that slot will go forward, obstruct those collaterals also. It happens also. Because as it is, opening of the artery does not mean myocardial. Okay. That's another very important element. So the time is essential whatever you have to do in the case of Sethi has to be done first 2 hours, first 6 hours, at the most first 12 hours. Even if you extend all your imagination up to 20, after 24 hours, the opening of something has to be done very, very carefully. And not others. Now I will end on this only because the white will become too much for you. I want you to understand the ECG correlates with the anatomy. Okay. So how many leads are there? Two. One person. Please. Yes. 12 leads. Name them, please. Give this. V1, V2 is not there. Last time. Now, V1, V2, AVR, AVR, AVR. V1, V6. Okay. One would be AVR, AVR, AVR are 6 days like that. V1 to V6 are 6 days. Okay. Come on. Virtually, place these 12 leads, virtually those. Imagine these 12 leads are your cameras, looking at your heart from various directions. Place these leads virtually over this heart. Where all these leads are. People need to be taken. I don't know what that is. Towards that. People say V6, one could be area. This take camera है, place the camera. Imagine this is V1, place V1. V1 कहाँ है? V1 कहाँ है? एक point पर है. These 2-3 areas. Transfer section. I want this is this transfer central. Any volunteers? Please. Okay. previous जैसे होता है वो बातें करनी जिंदगी में काम करना ओके और आप बताइए कहाँ लीड करती है कहानी में कोई सुनती है कहानी कर रहा हूँ बताओ पॉइंट तो लगता ना हम बताओ कि हमें जानना नहीं है यार ये कुर्सी है तो ये कुर्सी है ये थोड़ी बहुत कुर्सी है तवाल से बोलेंगे 10 मीटर चलती ना हो ये लगती है ना तो I had a 4 months seeing a cardiologist, much less. So, the other volunteer, please. This is very important. Very, very important. I will end the class with this. We're not watching tomorrow. We were listening. So, हमारा कॉन्सेप्ट है B6 सबसे पास किस है B6 जो है B6 सबसे पास कौन सा कैमरा है So you have to understand better right? Given your DM, his DM. You have to understand these leads are okay. सब बड़ा होगा, सब diagram देखना है, सब ऊपर देखना है. Because again, as I told you, you have to see in 2 dimensions, and you have to imagine in 3 dimensions. What you see here is a 2-dimensional situation. It tries to show 2 dimensions, but you see in red is a transverse section, and in blue the coronal section. They are again 90 degrees, right? So V1 to V6 are spread in this section. There are cameras looking at V1, V2, V3. They are capturing, these are cameras that are capturing the electrical activity of the car in a transverse section like this. They are coming like this. And your other leads, 1, 2, 3, ABR, are capturing the image, capturing the electrical image. I am using this camera computation to make it clear. But they are capturing the electrical activity in coronal section, as Hannah just told me. If they are running, we will need to be like this, 2, 3 ABR, 1 ABR, yeah, like this. They are running the camera. So V1 to V6 like this, 2, 3 ABR like this. Naturally, you have 1 ABR, you have here. So now, are we clear on this one? So now, the patient has a very expected disease. Patient has a lateral lateral left ventricular wall infarction. SC segment elevation. In which leads will you get SC segment elevation? Now, before V5, V6, any other lead? One NAV, both, one NAV. So you have a lateral wall infarction, you get ECG changes in before V5, V6, one AVA. You have an inferior wall infarction, which leads AVA 2 and 3. Okay. After this, you have a right ventricular infarction, which is the most specific lead. Which is the lead which is unique for right ventricle. AVR is looking at heart from this angle. There is another lead that is looking directly at right ventricle. V1 is looking directly at right ventricle. Okay. So if you get SC segment elevations in precordial leads, because V1 elevation is more than V2, let's say V2 will put on happen. It's the right side. V2 onwards, elevation ज़्यादा होता है. To left, interior wall myocardial infarction generally presented as segment in V2, V3, V4. Although V1 will be changed nothing for this. Okay, thank you. Are you clear? Right ventricular once later. V1. So let's say circumflex neck infarction, lateral side. Okay. There is SC segment elevation हुआ V4, V5, 1 AVM. होगा ना? बदल दो. Already done. Lateral wall infarction हुआ, circumflex सर्कमफ्लेक्स करेक्ट है बिल्कुल एक्ट हो कौन सी लीड करेंगे और एरियल F1 इसमें एलिवेशन होगा जनरली ईसीजी रेट्रोग्रेड करता है जिस साइड से में एलिवेशन हो रहा था उसमें उल्टी तरफ डिप्रेशन हो रहा था इसमें कोई डिप्रेशन की स्थिति नहीं fever area is a very unique lead that's generally not found in cardiology because it's very different it's not अभी आप लोग एरिया को जाइए एरिया कि एरिया area is looking at heart in this direction. And generally, यहाँ पे खास structures होते हैं. AVR में ऐसे segment derivation generally points towards the left within function. तो जो left में ऐसे curve लेके जा रही है तो एक छोटा सा area होगा. So here we are. That's very good. और देख रहे हैं इसको. ये transverse section में heart है. और transverse section में इसको V1, V2, V3 इसको देख रहे हैं. अगर हम कोरोनल सेक्शन काटेंगे तो इसमें ये और ये 1 और B6 nearly एक लोकेशन whatever changes you get in B1 will also get okay अभी last thing and then I'll show you some photographs finally understand. But I'll ask you a question. That's again question that not be इसमें एलडी का इंफॉर्मेशन है एलडी मत हुई एलडी का इंफॉर्मेशन कहाँ हुआ जुमा प्रोजेक्ट के लिए व्हाट्सएप छोड़ दिया एलडी का इंफॉर्मेशन हाँ एलडी का इंफॉर्मेशन लेफ्ट करते डायगोनल लाइन कहाँ होगा इस पूरे हार्ट का मसल कहाँ डेड होगा ये रेगुलर है कैसे सेकंड एलिवेशन मिलेगा एलिवेशन कहाँ मिलता है एंटीरियर वॉल एंटीरियर में फंक्शन कहाँ होता है V2 V3 एलईडी के फंक्शन V2 V3 होता है पहले तो यहाँ पे फंक्शन हो रहा था we were getting AC segment elevation in V2, V3, V4, V5, two best segment elevation था. आपने उसको कुछ नहीं किया, आपने probability अब ये पूरा ऐसा segment settle हो गया. तो इसलिए क्या चीज बनेगी? segment जब settle होता है, क्या convert होता है? क्या बनता है? Two wave बनती है. AC segment elevation हमारी is also called as two wave. ये two wave है. That's my question. फंक्शन हो जाने के बाद जब वहां पूरा मसल डेड हो गया है टू वे so it becomes an electrical window, a hole in the heart, right? In a transmural infarction, there becomes a hole in the heart. And what you start to see when there is a hole here, तो यहाँ पे छेद तो क्या लिखेगा? तो अक्रॉस क्या लिखा है? हाँ, सेप्टम लिख रहा है। सेप्टम लिख रहा है ना? सेप्टम का इनिशियल डिपोलराइजेशन जो है, टैक्स वहाँ होता है। तो इसके अवयव two ways. Start to see the septum through a electrical hole in the heart. That is the reason. Now coming back to the classification of the mitral system. Now coming to the classification of MI. SC segment elevation higher, transmural infarction. Higher thickness of the muscle comes head. Then SC segment elevation in non occupied by I told you this transflural infarction is not there. Some layer of muscle gets with other layers. Just because other layers are left, you will never get a window. You will never see the other side. You will never get a Q wave. Right? So all these nomenclatures are interconnected. Are we clear? The people who want to make clear, are we clear? I want to end here, but I just want to show you something. Yes, want to see. So, आपने normal angiogram में देखा था? क्या normal angiogram होता है ऐसा? Same view. लेकिन ये देखिए LED में यहाँ contrast पूरा हो रहा है. LED में left में circumflex, obtuse marginal branch of circumflex supplying the LED lateral wall. And this is the main left atrial descending. This is the diagonal artery supplies the lateral artery. Now, these two arteries look very far away. Actually, in three dimensional, they are supplying almost the same area, the left surface of the heart. The complex obtuse marginal branch of circumflex and the diagonal branch of the area. Here are the septal branches of the area. This area now here with almost 95-96. The artery there in line. But that day, that is the solution. What we do is we cross the wire across this, dilate it to the balloon, make some space, then implant the stent that it doesn't narrow. That's the whole process of implant. This is our job. Here again you see right coronary artery. This is the normal artery. This is the PDA, PNB, 90 between there and there is 90 degrees. These are the right ventricle, other branches of artery. Somewhere here, this stenosis that is around 90% there, around 70% there. And here something is what you see here is something called ectasia. And when you have a disease, there is a muscle called dilates. Normal vessel looks like this, firm, pipe-like structure. That can expand and recoil, expand and recoil. Whenever you have something like this here, ectasia, we have more specialized instruments to see inside coronary arteries also. Happen frequently. Something that we have called as OCT. And we have two ways in which we can. Now, angiogram is an indirect thing. It's a contrast and you get an X-ray. You are trying to see a shadow, not actually seeing the region, you are seeing a shadow of the region. And there, we can take intravascular ultrasound, we can take small probes on that wire that we have crossed. We can do an ultrasound with it. And we also have something called an OCT. When you do an OCT, maybe more than 10 days before OCT, we can do this on a procedure. Come and see how OCT is. You can see inside the arteries. It is possible to go and so images. What you see here is a stent. The region the antiparty is completed. We are looking at the final picture. What you see here is the metal of the stent. So just because metal is opaque, every light in ultrasound images, what you see here is the shadow of that metal that's called as a sunray. Okay. This is an OCT image in which you have this stent space inside. This is another stent space inside. You can check by OCT. We also have techniques to measure whether what lesion that we are seeing. Now you see this lesion. And you will say it is 60. I will say it is 60%. And people here will say 80%. How are we sure? How do we objectively document ischemia inside CAT-lab? We can do it in other ways outside CAT-lab. Better than this. Okay. So how do you do it inside CAT-lab? Now I see lesion. Whether should I put the stent or not? So there's something called the fractional flow reserve. You have a wire. It's got a pressure sensor and it's here. Okay. So you can cross this wire here. We can measure the pressure in this catheter, pressure in the aorta, and we can measure the pressure distal here. If there is a pressure drop, means think of something severe, and we can say that is called as a maximum flow reserve in any FFR of less than 0.7, 0.75 significant. See here the pressure increase. Aortic pressure. A lot of things that people have told you, but I think it's enough for today. I'd like to want to believe that you have captured something other than stupid. I'm not sure whether it was too high for you or too low for you or whether one of you that's learning a little more about cardiology and find the fields to share exciting for you. If you're always there to guide with your heart, with all of this.
Thank you, sir. Thank you so much. All of you, please sit down.
Sir, it is really very wonderful lecture. I think all of us enlightened by this. And the way you teach students in a very simple way, I think, and very captivating method of teaching, I should say. And on behalf of Department of Anatomy, I am thankful that you have taken your precious time out of your busy schedule. Thank you so much, sir.